So we're going to do signs and symptoms of stroke. So the first thing we need to recognize is that there are actually different types of strokes, if you want to call them, based on the patient's symptoms. So we can have a patient who can have what's commonly referred to as like a mini stroke. There we go. Hello. So you may hear the term mini stroke, like a patient having something called a mini stroke. This is usually what they were referred to in the hospital as something called a TIA. So the first thing, we're going to break up stroke into transient versus permanent. So we have transient symptoms, meaning that the symptoms appear, they last for a certain amount of time, and then the symptoms go away, versus a patient that has permanent symptoms. So under transient, the first thing we're going to have is something called a TIA. TIA. So as the name implies, this is called a transient ischemic attack. TIA may also be referred to as, this is your mini stroke. Oh, it's a mini stroke. So with TIA, the important criteria with this one is that the neurological deficit completely recovers within 24 hours. So that 24 hours, that's going to be key for your registry to remember. So these are patients that'll come in exhibiting stroke symptoms. Maybe they're unable to talk, they have gargled speech, they're having weakness on one side, facial droop, dizziness, vertigo. We're going to go over all the different signs and symptoms of a stroke. But these patients, they come in with symptoms, and the symptoms resolve completely within 24 hours. And the source of these TIAs is usually due to an embolic episode. Usually due embolic episode. So what that means is that it's usually like a little piece of plaque that might break off, say from the carotid arteries, that travels up to the brain and lodges one of the arteries within the brain. Could potentially be from a small thrombus within the heart. That's another option. So with these TIAs, these are time sensitive. So what that means is if we can get to these patients quickly and administer a medicine called TPA. TPA is the medication. This is medication. In 3 hours of onset of symptoms, we can prevent permanent damage. So this TPA, this is a clot busting medication that gets administered in the hospital. And if we can administer it fast enough, within those onset of symptoms, we can prevent the stroke from progressing. So TPA, that's the medication. So TIA, transient ischemic attack, also referred to your mini stroke. Those are patients with symptoms that completely resolve within 24 hours. As we move along, we have a second type of stroke that's referred to as a RIND, R-I-N-D. So this is reversible. Ischemic. Neurological deficit. Deficit. So with this one, patients fully recover within 3 weeks. Fully recover within 3 weeks. So both the TIA and the RIND fall under the transient category. And under the permanent category, we have our CVA. This is a cerebrovascular accident. Cerebral or cerebrovascular accident. So this is your true stroke. So the CVA an ischemic attack that lasts longer than 24 hours has been found to show profound cerebral damage. So these are permanent. Neurological deficits. And then there's two types of CVA. We can have an ischemic stroke. So ischemic stroke is due to a blockage in the artery. Or we can have a hemorrhagic stroke. Stroke. So the hemorrhagic stroke is actually when you have a bleed within the brain. You can put this down as a brain bleed. Brain bleed from rupture of vessel. So for the ischemic, some causes can put down. Main one is going to be from atherosclerotic plaque, atherosclerosis. We can also have from thrombosis. So we can have clot developing within a vessel. Or it can also be from embolism. So those are our three main causes of an ischemic stroke. So atherosclerosis is going to be our most common. That's typically when we have plaque within the arteries that's building up. Thrombosis, we can have thrombus actually developing within the vessel, or embolism. The clot could be from another source and travel to the brain. under hemorrhagic. So we said that was from the rupture of an artery or a vein, actually. So that's our brain bleed, so rupture of vessel. Rupture of vessel. So then causes. Over here we can put hypertension. Or high blood pressure. Again, we're going to put atherosclerosis. Or rupture of aneurysm. So we can have, under hemorrhagic stroke, we can have parenchymal. Put down cerebral hemorrhage. So parenchymal or cerebral hemorrhage. That's usually due to high blood pressure. High BP. And we can have a subarachnoid hemorrhage or stroke. Arachnoid hemorrhage. And that is usually due to an aneurysm rupture. Aneurysm. So another term that you might encounter is something called a cryptogenic. Cryptogenic. That's CRYTOGENIC. Cryptogenic stroke. So basically, that just refers to a stroke of unknown cause. No. And you may also hear a term called a hypotension stroke. Hypo, so low blood pressure. So the low blood pressure reduces oxygen supply to brain.
Dan,
Yeah,
so are these all still considered permanent?
yeah, so this is all under permanent, yeah.
Okay, just wanted to make sure I didn't miss anything. All right, thank you.
Yeah, so anytime we use the term stroke, like a real stroke is going to be our CVA. So that's really a stroke. Patients who've had a stroke are the ones that have permanent damages. You may hear patients had a TIA. So that's actually different from the actual word stroke. In the hospital, they use the term mini stroke because the symptoms, they come and go. So a TIA really isn't a true stroke. A true stroke is someone that has these permanent neurological deficits.
Dan, I have a question too.
Sure, yeah.
What is an acute stroke? Like my grandma had an acute ischemic stroke, and I was like, I don't know what the difference between a transient and acute is.
So when we talk about acute, it's acute versus chronic. So an acute stroke would be something that happened, all of a sudden. So that was probably maybe due to like an embolic event where she had like her arteries were fine normally, and then maybe a little piece of plaque broke off and blocked the artery acutely all of a sudden.
Okay.
Whereas a chronic stroke may due to atherosclerosis, like a slow buildup of plaque over time that narrows that vessel.
Okay.
And limits blood flow. So an acute's a sudden rapid onset for a process that happened all of a sudden. It's something that wasn't there before, and all of a sudden now it's an issue. So that's what an acute means.
Okay, that makes more sense. Thank you.
How's she doing?
She's still in the hospital.
Oh my gosh, so this is recent.
Oh yeah, it was Friday. That's why I was
my
curious. I'm
God.
like, what are the odds we're talking about this today?
Oh, I'm so sorry.
Yeah. No, it's fine. It's nice to learn about it and like know more about what's going on. So it's cool.
So this next little bit is going to be a large portion of your probably vascular registries, and it's important for you to really understand the symptoms, because the symptoms will tell us a lot about which vessels are involved and where the blockages and problems could potentially be. So as we know, the brain circulation is broken into the anterior and posterior circulations. So there are symptoms that can go along with blockages in each of these circulation pathways. So we're going to do first the anterior circulation territory symptoms. Anterior circulation. anterior. All right, so anterior circulation. So we know that is going to include our ICA, ACA, anterior cerebral artery, MCA, our middle cerebral artery. We can also throw in here the ophthalmic artery. As well as our anterior communicating artery.
Hey, Dan, will you move the camera over a little bit? Thank you.
So with the anterior circulation, these symptoms are known as lateralizing. So that's a term that we use so that it can indicate which side or hemisphere of the brain is being affected. So with lateralizing, we can determine which hemisphere So when we're talking about the brain being divided into hemisphere is going to be right or left. So which hemisphere slash side of brain is affected? So anterior circulation, these are lateralizing symptoms. Lateralizing, we can determine which side or hemisphere of the brain is affected. Alrighty. So the first one is going to be paresis. So paresis is a weakness or slight paralysis. So we put weakness or slight paralysis. And this is going to be unilateral. Oh, dear. Unilateral. And not to get confused, we have another symptom called paresthesia. Oh, sorry, sorry, P-E-R, sorry, P-A-R-E-S-I-A. STH. So this is a numbness. Or tingling. Some patients even describe it as a burning sensation. And again, this is going to be a unilateral symptom. Actually, something I forgot to mention that we might see. So we can actually attach onto these words the term hemi. So we can do a hemiparesis, hemiparesthesia. So that term hemi is another way we can describe that it's unilateral or one side. So hemiparesis, hemiparesthesia. Also have hemiplegia. Hemiplegia. So this is actually going to be full paralysis of one side of the body. This is full paralysis. One side body. All right, so far we have hemiplegia, that's paralysis of one side of the body. Hemiparesia, that's a slight weakness or slight paralysis. So with paresia, think of just like say right-sided weakness, like they could still use their limb, but they're just weak in that limb. It's not as strong as the other. Hemiplegia would be a full paralysis of one side of the body. They can't move that arm or limb at all. Hemiparesthesia or paresthesia is that abnormal sensation of like burning, prickling, tingling that affects one side of the body. We also have symptoms of aphasia. So aphasia is lack of speech. Or we can also have dysphagia. And that would be difficulty speaking. So aphasia, these are the patients that, they can't even speak at all. They don't even say a word, you ask them their name, they just stare at you blankly. Dysphagia will be the patients, that you ask them a question, like what color is the sky? And they say like pizza or something, like the words just don't make any sense. So dysphagia, difficulty speaking, they use incorrect words. Incorrect words. This would be like gargled speech also. So the reason speech symptoms actually falls under this lateralizing symptom that we can determine which side is affected is that speech so with speech, dominant hemisphere is affected. So the way we determine which is the dominant sphere is we base that upon the patient's handedness. So if patient is right-handed, is right-handed, left brain controls speech. And we consider them left brain dominant. Left brain dominant. So if we think about that, so if we have a patient that, is unable to speak, they're having dysphagia or aphasia, difficulty speaking. And we're able to determine, if we know that they're right-handed, we can then assume that that issue is going to be affecting the left side of the brain. So, and then we could do vice versa, reverse that. So if a patient is left-handed and they're having speech deficits, then we know it's the right side of the brain that's affected. So it's right-handed. Left brain is affected. So we can also have some visual disturbances as well. So this is I can't even pronounce this, homonymus homonymus hemianopsia. Should I say that fast? Homonymus hemianopsia. So this is a blindness or visual defect in half of your vision field. So kind of think about it like putting your hand over half your eye and half your vision in one eye is disrupted. This is vision disruption. And one eye of half your vision field. The more common vision disturbance that you're probably going to encounter and that you'll hear on your registry exams is going to be called amaurosis fugax. So it's right. Amaurosis fugax. There we go. So amaurosis fugax is also referred to as transient monocular blindness. Blindness. So the key word under this is transient. So this is going to be a temporary. Partial or total blindness of only one eye. So sometimes they refer to this as pulling the shade down over your eye. So the eye just kind of, you wind up in one eye, like going partially or totally blind in that one eye. Like that's what doctors in the hospital kind of refer to it as. With amaurosis fugax, it's important to remember that this is going to be an ipsilateral symptom. So it's ipsilateral, so it occurs on the same side of the brain as the eye that's affected. And it's due to occlusion of the ophthalmic artery. Due to occlusion of ophthalmic artery. All right, so all those symptoms that we talked about, the way I kind of remember this is that symptoms that happen kind of below the level of the head. So like all the paresthesis and the paralysis and the hemiplegia and the weakness, the paresis, those symptoms that happen below the level of the neck. It's the opposite side of the brain that's affected. So symptoms below of head are contralateral to vessel involved. So that's how we can, refer to them as lateralizing. We can figure out, which side of the brain is affected. So symptoms below the level of head are contralateral to vessel involved. So right-sided weakness is going to be left side of the brain. Right-sided numbness is going to be left side of the brain. Left-sided numbness is going to be right side of the brain. So the symptoms above the brain, the amaurosis fugax, are going to be ipsilateral, the same side of the brain. And then with speech, we have to determine handedness, to be able to figure out which side of the brain is affected. So symptoms below the level of the head are contralateral to the vessel involved. Amaurosis fugax. Fugax is going to be ipsilateral, same size.
Is that the same with the hemianopsia?
Yes, yeah. Yep. The difference between the two is that the patient will still have vision, just half of it's going to be cut off. It's kind of strange. So then when we get into the posterior circulation, these are considered non-lateralizing symptoms. So with posterior circulation, again, posterior circulation. So the vessels now that are involved, we have our vertebral artery, vertebral, basilar, PCA, our posterior cerebral artery, and our posterior communicating artery. So again, posterior circulation, this is going to be non-lateralizing. So that means we can't determine, which side of the brain is affected. So with this is going to be bilateral. Vision. disturbances. We can have diplopia. So diplopia, that's going to be double vision. You also have drop attacks. So that's falling to the ground without other symptoms. No loss of consciousness. So with drop attacks, there's no loss of consciousness. That's a person who just kind of falls. They just kind of, as the name implies, they just fall to the ground. You can also have syncope. So with syncope, that's actually a fainting or blacking out. So that's a transient loss of consciousness. So it's a little bit different from a drop attack. So syncope, we can call this one, fainting. And fall to ground. With loss of consciousness. Another big one is going to be vertigo. So that's a sensation, that you feel like the room is moving or spinning, I kind of like to think of it as like, you go to maybe the edge of a cliff or the edge of like, someplace really high and you look over the edge, and all of a sudden you start feeling dizzy, or it's kind of like a loss of equilibrium. So vertigo, so like room is spinning, loss of balance. So we can also have dysphagia. So don't confuse this with dysphagia. Dysphagia, that G in it. This is actually difficulty swallowing. I know the registry sometimes likes to trip you up on dysphagia versus dysphagia. Dysphagia with the G is difficulty swallowing. Now, bilateral paresis. Bilateral anesthesia. Yeah. Dizziness. Headache. Confusion. Noise disruption. Or noise disturbance. Is that a word? So the patient will hear noises. And also lastly, ataxia. So ataxia, that is loss of muscular coordination. Also. So what that is you ask a patient, all right, touch your nose, they're not able to touch their nose. They go off to the side, or they here reach, grab this pen, they're unable to like, coordinate their muscle movements to grab a pen or reach for something. So that's loss of muscular coordination. It can also be, if they're trying to walk, they walk with like an uneven gait. They can't even, coordinate their muscles to be able to walk. Be another example. So the big takeaway with posterior circulation is, symptoms are usually bilateral vision disturbances, bilateral paralysis, bilateral numbness, bilateral weakness, your symptoms of dizziness, loss of consciousness, vertigo, drop attacks, noise disturbances, confusion. So we're going to talk now about atherosclerosis. So 15% cerebral infarcts are associated embolic or thrombi from atherosclerotic plaque at the carotid we'll put carotid bulb / bifurcation. So the takeaway from that is that when we're doing our carotid ultrasounds, it's really important for us to look at that bulb and bifurcation area, because that's where most of our plaque is going to wind up building up in these patients. And it's that plaque that breaks off and creates little emboli that travel to the brain that make up roughly about 15% of all stroke cases and incidences. So under atherosclerosis, we also have something called arteriosclerosis. So when I look at those two words, they look pretty similar. I look at that first root, art. And I don't know about you guys, but I'm a terrible artist. For me, art is hard. So the way I remember this is arteriosclerosis is the hardening and thickening of the arteries. So atherosclerosis, is the buildup of plaque. Arteriosclerosis is the hardening and thickening of arteries. So these processes, like we said, they most commonly occur at the carotid bulb and bifurcation. So commonly occur at carotid bulb bifurcation. As well as the origin. So coming forth, well, sorry, as origin and distal ends of vertebral arteries. And the proximal and distal ends of the basilar artery. Basilar artery. So with the cerebrovascular disease, we often find our disease where blood flow is going to be changing direction. So with the vertebral arteries, we have them branching off the subclavian. So you have your blood flow and say the traveling up the subclavian, and it hits that branch for the vertebral artery. So that blood flow is going to change in direction. So that change in direction of the vessel is an area where we get disturbed flow. So we can wind up with plaque developing there. And then the other end of the vertebral artery, when they're coming together to form that basilar artery, we get another change in flow direction, two vessels coming together. So we have a disturbance in flow. We don't get that nice laminar flow. So that's another site where we could potentially develop, atherosclerosis and plaque buildup and hardening of the arteries. So if we think about that also, that basilar artery, where it comes together. So the proximal basilar artery is another site. And then that basilar artery then splits into your posterior cerebral artery. So where you get that divergence of the vessel again would be another site where we can wind up with plaque development and hardening of the arteries. So another potential source of embolus could be embolus from heart. Embolus. Heart. So for embolus of heart, some sources. So we can have valve vegetation. So a valve vegetation, that's when a patient has an infection in the heart, and the infection affects the little valves in the heart, particularly on the left side of the heart, the aortic valve or the mitral valve. They develop these little strands of bacteria that collect on the valve that can break off and travel. So valve vegetation, you can also have intracardiac thrombi. So this is clots within the chambers of the heart that could potentially travel. Again, this is going to be the left side of the heart. Myxoma. Cardiac arrhythmia. So the big one for that would be AFib, atrial fibrillation. Atrial fibrillation. For AFib, that's atrial. Other sources of embolus from the heart could be if a patient has prosthetic valves. Certain cardiac diseases like cardiomyopathy. Bacterial endocarditis. And we can also have hypertensive arteriolar sclerosis. Arteriolar sclerosis. Hypertensive arteriolar sclerosis. So with this elevated BP, blood pressure can contribute to heart disease. Contributes to heart disease. The elevated blood pressure worsens atherosclerosis. So that elevated blood pressure is going to lead to an increased buildup in plaque. The high blood pressure will injure small vessels of kidney and brain. Injures small vessels, kidney, brain. And this could lead to an occlusion of the arterioles. Lead to occlusion of arterioles. All right, so next thing we have is a carotid dissection. Carotid dissection. Carotid dissection often occur distal to the carotid bifurcation. And dissection can lead to stenosis, occlusion, and false aneurysm formation. So do we all know what a dissection is? It's a separating of that intimal layer, that inner lining of the vessel wall, where we get kind of like a true lumen and a false lumen when we image it on ultrasound. All right. So another thing that we should also remember is that some patients may have pre-thrombotic states, meaning that they may be more susceptible to developing clots due to coagulation issues. So underlying clotting disorders are a significant cause of stroke in young people. So if you have a young person, that is exhibiting signs of stroke, more often than not, it's going to be a result of some underlying clotting disorder that hasn't been discovered yet. So they require, a good blood workup and patient history, to determine that. So more likely than not, it's going to be an embolic stroke. So another thing that we can have is something called a vasospasm. So vasospasm is a narrowing lumen and intracranial artery. due to contraction of smooth muscle. Due to contraction of smooth muscle wall. Or to morphologic changes of the blood vessel wall. So with vasospasm, the way I think about this is kind of like maybe like the vessel kind of cramping. So that muscular wall of the vessel, that smooth muscle wall, constricts and squeezes that vessel and changes the shape of the vessel, changes the morphological shape of that vessel, and creates a narrowing or a stenosis, within that vessel, that artery. Vasospasms can be seen after a subarachnoid hemorrhage. So put that over here. Seen after subarachnoid hemorrhage. Right out of room. Subarachnoid hemorrhage, and is a significant cause of stroke. So that brain bleed is going to put pressure on those vessels. And create those morphologic changes to the vessel lumen. Associate vasospasms with subarachnoid hemorrhage or brain bleeds. When we do our TCD rotations and we go to the hospital and doing our transcranial Dopplers, I mean, that's one of the big things that they're looking for with these stroke patients that have had hemorrhagic strokes. They're looking for vasospasms. when they're Dopplering these intracranial arteries. All right, so some risk factors that contribute to carotid disease. Risk factors. So we're gonna have all the usual suspects. Smoking, hypertension, diabetes, hyperlipidemia, that's your high cholesterol. Heart disease. And we can do another subcategory of other. Under here would be, age, gender, race, family history, obesity, go back under here under heart disease. The big one's going to be our AFib, our atrial fibrillation, AFib, atrial fibrillation. This is actually shown to increase your likelihood of a stroke by 6 times more likely. To have stroke. And under heart disease also, we can put a condition called mitral valve prolapse. Mitral valve prolapse. And this is would be a major source of stroke in young people. Major source. Stroke. Young people. Alright, so I'm just gonna switch back over to the PowerPoint now, because there's some images that we can go through. All right, so as we know, two most common, oh, too fast. All right, so the two most common causes of brain ischemia or cerebrovascular insufficiency, so lack of blood flow getting to the brain, or hypoperfusion or low perfusion of blood flow to the brain, caused by either stenosis, occlusion, embolism, or thrombosis, or embolization. So the embolization or that clot breaking off and going to the brain could be from aneurysm, dissection, other causes, could potentially be a carotid body tumor, subclavian steal syndrome. All right, so these are now some pictures when we get into imaging the carotid arteries. So we have our picture here of a carotid artery, so our common carotid artery coming up towards our head. We get our bulb and then our bifurcation. So when we put our color on, it looks like this artery is occluded, we don't see any flow within it. And if we move down a little bit further, we were able to pick up some areas of flow a little more distally. So that artery isn't completely occluded. So this is an example of something called trickle flow. So within this vessel, we're going to exhibit very low velocity flow. You may actually need to put on your power Doppler to be able to even pick up this flow because the velocities might be so slow. This is another image showing that ICA trickle flow. So this is an image showing a CCA occlusion. So we're getting no flow in the CCA, but when we put our color box over here, we're able to see flow within the ICA and ECA. So if we look at our color box to kind of show us the flow direction, so we have red as going towards us. So if we think about this, the ultrasound beam is headed in this direction, and our CCA, the blood flow, is coming towards that beam. So we have that exhibited as red coming towards us. And then the ICA is actually blue, so that's going away from us. So that's headed up towards the brain. So what's going on in this scenario is we're getting retrograde flow. Yeah, I'm here still. We're getting retrograde flow within the ECA, coming back up and going into the ICA and going up to the brain. So we're getting a steal syndrome, a retrograde flow in that ECA due to this occlusion in the CCA. So this is an example for an ICA occlusion. Again, we have our CCA coming up towards the brain, get our carotid bulb, and then we have our bifurcation. So then we see the CCA, no flow. When we Doppler, we won't get any Doppler signals. And we also now are seeing flow within the ECA. And it looks a little turbulent because we're getting some aliasing here. So this is probably a stenotic ECA as well. So with hyperperfusion, we have thrombosis. This is formation or presence of thrombus, clotting within a blood vessel, which may cause infarct of tissue supplied to that vessel. This could be secondary to stenosis or embolism. So with embolization, this is a foreign substance or a piece of thrombus that moves through the circulatory system until it lodges in a distant blood vessel, causing an embolism or by completely or partially obstructing that vessel. If we know the heart is the most frequent source of emboli, another source is from atherosclerotic plaque. An aneurysm is an abnormal localized dilatation of a blood vessel due to a congenital defect or a weakness of the vessel wall. So aneurysm could also be caused by trauma, infection, atherosclerosis, or congenital defects. And these aneurysms rarely occur in the cervical carotid artery. So the carotid artery that we see within the neck, we typically don't visualize aneurysms. These aneurysms are typically found in the intracranial vessels. But if we do see an aneurysm, this picture shows an example of a common carotid aneurysm. And they were able to treat this aneurysm by placing a stent. So a carotid dissection, this is entry of blood under arterial pressure into the wall of the artery, separating the artery and creating a false lumen. Can occur between the intima and media, within the media, or between the media and the adventitia. So the etiology, some causes are the congenital defect, fibromuscular dysplasia, FMD, trauma, neck manipulation, neck pain, underlying weakness of the muscular layer that may allow the intima to tear. So with this, you have the true lumen and the false lumen. False lumen may be blind ending, and you have thrombus formation or occlusion in that false lumen. And the bulge into the true lumen may cause a stenosis or an occlusion and may reconnect with the true lumen. So carotid dissection, it's usually asymptomatic and may present with hemispheric ischemic symptoms, headache, facial or neck pain. So some consequences, again, for carotid dissection would be stenosis or occlusion of the artery, development of a pseudoaneurysm, or recanalization. So it's usually treated with antithrombotic and antihypertensive medication. So it usually originates in the aortic arch and may extend cephalad into the CCA and into the bifurcation branches and the ICA. Cervical carotid arteries may undergo distension spontaneously. So under carotid dissection, you should also put a couple of these conditions here. So as well, along with hypertension and fibromuscular dysplasia, people with Marfan syndrome or Ehlers-Danlos syndrome are susceptible to developing carotid dissections. These are connective tissue disorders. So that may potentially show up on the registry, particularly Marfan syndrome. So what does the dissection look like on ultrasound? So you could potentially in transverse see that intimal layer, the flap. So this would be a transverse view. A thin dissection membrane that moves freely within the arterial lumen. And when you put color on, you can potentially see two distinct channels of blood flow. So again, this is another transverse view of a dissection. You see that the intimal flap. And then when you do a longitudinal view, it elongates. And then when you put color on, you see two distinct channels of blood flow. But when you Doppler the two channels of blood flow, you can notice differences within the spectral tracings. So A appears to have a normal, carotid waveform where you're getting biphasic flow. And when you Doppler the other channel, you see a flow reversal. So this is going to be your false lumen. So lumen A is true lumen with continuous forward flow. Lumen B has to and fro flow, so bidirectional flow. So this is another image here for your CCA dissection. Again, showing two channels of flow. This one red, one blue. When you Doppler, this has continuous forward flow, and you Doppler the other one, you're getting your bidirectional flow. You get systole in one direction and then a flow reversal during diastole. So like we said, we could develop thrombus within that false lumen, which can create a narrowing or stricture or stenosis of the true lumen. So this is a picture showing high velocities, because of this area being thrombosed, the false lumen is now constricting the true lumen, creating a stenosis, and we wind up with elevated velocities. So aortic dissections, we can break those up into two categories, a type A and type B dissection. So this, see me. So this is the Stanford's classification of dissection. So type A. So this one involves the ascending arch. So type A is ascending aortic arch. We draw our aorta. That's going to be a dissection that involves the ascending arch. We have our vessels coming off. So since it involves the ascending portion, the proximal portion of that aorta, the type A's will have CCA extension. And it's usually caused by atherosclerotic disease, or atherosclerotic disease, or connective tissue diseases like Marfan syndrome or the Ehlers-Danlos syndromes. atherosclerotic disease or connective tissue disease. That's going to be our Marfan's. And LER. Ehlers Danlos. Syndromes. Okay, so then type B. So type B. This is going to occur distal to aortic arch. Yeah, aortic arch. So it's going to be an annular dissection that occurs distal to that arch. We have our branches. This one's gonna usually does not affect carotid arteries. It usually does not affect carotid arteries. All right, so then we also have carotid pseudoaneurysms. So carotid pseudoaneurysms are most often a result violent trauma, percutaneous jugular vein catheterization, or therapeutic / diagnostic and angiography. So what that means is we can develop a pseudoaneurysm either from having violent trauma to the neck, or it could be a result of the doctors trying to put in a line in the jugular vein and they accidentally go too far and they hit the artery to create a pseudoaneurysm. Or it can be a result of potentially if they were intending to go into the artery for a diagnostic procedure like an angiogram or for therapeutic reasons. And then when they remove the catheter from the artery vessel doesn't close fully. And you wind up with a bleed. And that bleed gets encapsulated and enclosed and creates that pseudoaneurysm. So some other causes of a pseudoaneurysm could be a dissection. Other causes. Be a dissection. Pathologies that weaken the arterial wall, such as FMD. So that's that fibromuscular dysplasia. Marfan's. And Ehlers-Danlos. So may present with a palpable, so you can possibly feel it palpable, pulsatile, pulsatile mass. May hear a brewery. So you can potentially hear a brewery. May have neck pain. So what is this gonna look like on ultrasound? Okay, so we have our native artery. This is our native vessel. So we can call it, common carotid artery, ICA, any vessel, any artery. So when that artery gets punctured, blood flow is now leaking out of that artery. So blood flow is coming through what's called the neck into this cavity or this space that becomes the pseudoaneurysm. So the body kind of encapsulates this bleed to prevent you from just kind of bleeding out. So blood flow comes through out of the artery, through that neck, into this area here and begins to swirl. So a telltale sign of a pseudoaneurysm, we wind up with something called a yin yang sign within this pocket, this area, where one side will appear blue, and the other side may appear red. I mean, it's not going to be a perfect yin yang, but you see this swirling appearance of blood flow. So this is active bleeding going on when there's an active pseudoaneurysm. Over time, this may become thrombosed, if they apply pressure to it. There are procedures where we actually inject thrombin or a clotting agent to close this off, to seal off this bleed. But the important characteristic when we're Dopplering and visualize a pseudoaneurysm is going to be in this neck. So the neck is going to demonstrate bidirectional flow. Demonstrates bidirectional flow. And it's a really unique flow pattern. When you're Dopplering, get a good Doppler tracing on that flow in that neck. So this is our baseline here. So typically when we get our pulsive artery, we're going to get a systolic flow into that neck. So we'll have an upstroke. And then we have a pretty substantial flow reversal during diastole. That's going to be our bidirectional flow. So systole will have, going towards that pseudoaneurysm, and then we'll get an abrupt flow reversal during diastole, a blood flow coming in, swirling around, and then going back out that neck during diastole. So if you go to the PowerPoints, there are some pretty good pictures that show, what the pseudoaneurysm will look like, a carotid pseudoaneurysm. So treatment. Treatment is surgery to repair the vessel wall or non-surgical wall stent. They can take the patient to surgery, try and close up that wall, or they could potentially put in a stent over that area within the native artery to repair. So for us as sonographers, our job here in diagnosing this is to determine size and location. Pseudo. So we want to know which vessel is the one that's bleeding. We want to determine the size of the pseudoaneurysm. But also equally as important as the size of the pseudoaneurysm is our measurements for the neck. So we're gonna also measure length and diameter of neck. So shorter and wider neck is worse. So a shorter and wider neck makes it more difficult to repair. We want a Doppler neck to demonstrate the bidirectional flow. Doppler neck to show bidirectional flow. And we also want to demonstrate the presence of any thrombus within this pseudoaneurysm. So if you can imagine, this is in your neck and you have your carotid artery going up to your brain. If we're starting to now develop a thrombus within the pseudoaneurysm, that thrombus could potentially embolize and cause a stroke. So we can also put down show presence of thrombus, show presence of thrombus. So next thing we're going to talk quickly about is fibromuscular dysplasia, or FMD. Fibromuscular So this is an abnormal fibrous and muscular tissue development. Fibrous and muscular development disease. This can also fall under that, connective tissue disease category, connective tissue disease. So most commonly defects. Renal arteries. Axillary. Iliac. Basilar. Carotid. Hepatic artery. And intracranial arteries. So this is the disease that you commonly hear referred to as the string of pearls or string of beads. So we'll put in quotes, string of pearls. / beads. String of pearl / beads appearance. Arteries. It's usually seen in young women ages 25 to 50. Seen women. /25 to 50. All right, so this is going to be our string of pearls or string of beads appearance. I'll draw that out in a second, what that's going to look like. It's usually seen in young women ages 25 to 50. It's an abnormal connective tissue disorder with abnormal fibrous and muscular tissue development that causes these arteries to have this string of beads appearance. So what's it going to look like? So if we have our artery, we'll get these little kind of focal areas of dilatation. Where it does kind of sort of look like a string of pearls. It's more often appreciated when we do an angiography. Sometimes it can be kind of difficult to appreciate, on ultrasound, especially when we're trying to assess like something like the renal arteries, where they're tough enough to image to begin with, but then trying to determine if there's, FMD on the renal arteries, it's can be quite challenging on ultrasound. So with fibromuscular dysplasia, the most common presenting symptom is systemic hypertension. And this is caused by renal artery stenosis. The most common symptom. Is systemic hypertension, HTN, due to renal artery stenosis. So with carotid involvement, patients could develop a TIA and also run the risk of cerebral hemorrhage. So with carotid involvement, patients run risk of both ischemic and hemorrhagic stroke. So they can have ischemic stroke due to that narrowing. So you get the bulging and then narrowing with this string of pearls. So it could be an ischemic issue, as well as the bulging, disrupts your laminar flow. So you can wind up with hyperperfusion based on the shape of the vessel. And then you also run a risk of that vessel rupturing easier due to its malformation. So they both run the risk of both ischemic as well as hemorrhagic strokes. Again, so here's some different appearances for fibromuscular dysplasia. So you could see the string of pearls, but it may not necessarily look like a nice string of pearls. This would be another example here. Some fibromuscular dysplasia. Angiogram showing distal ICA with FMD. FMD is usually located quite distally with the string of pearls appearance. So Doppler would show spectral broadening, so turbulence of the flow with spectral broadening and increased velocities. So here we can kind of appreciate a little bit, doesn't have that typical nice smooth walled appearance for getting these little bulges. This is a moderate flow disturbance and velocity evaluation for a patient with FMD. So with this picture, power Doppler showed the characteristic series of ridges. Again, another image. Patient with fibromuscular dysplasia, you could see the ridges, the bulging. So another thing that we could potentially have is something called a carotid body tumor. So a carotid body tumor. So this is a tiny ovoid structure located between the adventitia of the carotid bifurcation between the external and internal carotid arteries. This is considered a paraangiolipoma with low malignant potential. So I'm going to say paraangio. Lyoma, paraangiolioma, located between adventitia carotid bifurcation between ECA and ICA. ECA. So it's going to be highly vascular. And usually fed by ECA. Usually. ECA. Draw it here. Carotid body tumor, if you see it on your tests or on your boards, it says a very unique appearance that you're gonna know that it's only one thing. And it's mainly due to its location. So if we have our CCA and we split it to our ICA and ECA. So your carotid body tumor is going to wind up in the space between your ICA and your ECA. So in the textbooks, sometimes this can appear quite large. So you're going to see this ovoid mass sitting right in between your bifurcation. And that's where it's going to be located. So this would be your CCA, your ICA, ECA. So it's going to sit right in that bifurcation, your carotid body tumor. And it'll often displace your vessels in one way or the other. So one last condition that I'm just going to talk quick about is a subclavian steal syndrome. So with this is a condition where cerebral vascular circulation is shunted away from brain through the vertebral arteries. This is due to an occlusion stenosis brachiocephalic or proximal subclavian arteries.
And can you Thank you.
Yep, so it's a condition where you get blood flow shunted away from the brain through the vertebral arteries due to an occlusion or stenosis of the brachiocephalic. So on the right side, it could be an occlusion or high-grade stenosis in the brachiocephalic or innominate artery. On the left side, we don't have that, so it would just be the proximal subclavian. But it could also be the proximal right subclavian as well, as long as it's before that branch of the vertebral artery. So it's a proximal stenosis. You get a shunting of the blood flow away from the brain through the vertebral arteries. So you get retrograde or reverse flow in those vertebral arteries. And it's in order to provide blood flow to the arm. So you have this high-grade stenosis that's central in either the subclavian or the brachiocephalic artery. That's impinging or impeding blood flow getting to the arms. So the muscles of the arms need to get that blood flow. So the body is actually going to steal it from the brain through those subclavian, through the vertebral arteries. So we see retrograde flow in vertebral artery of the affected side. So what that means is the side that has the occlusion or the blockage, that's the vertebral artery that we're going to see retrograde flowing. Oftentimes, contralateral side will demonstrate increased flow. Increased. So if we have one side that has retrograde flow, the brain's going to try and compensate and increase flow in the other side, the contralateral side. As well as increased flow in ipsilateral, same side, CCA and ICA. I'm sorry, yeah, CCA and ICA, ECA. So we'll see increased flow in the CCA, ICA, and ECA on the same side. Particularly the CCA and the ICA going to the brain. And we'll erase CCA. So we'll see increased flow in the ipsilateral, same side, CCA. Oh, I put CCA and ICA. And that again is to kind of compensate for that steal that's going on in the vertebral on that side. The other thing that we're also going to see is a difference in brachial blood pressures between the two arms. So if we see a difference in brachial pressure of greater than 15 to 20 millimeters of mercury of greater than 15 to 20 millimeters mercury. We can suspect a subclavian steel stenosis. So the side that has that blockage is going to exhibit lower pressures compared to the other side because the blood flow is not getting to the arm accurately when we're taking those brachial pressures. So pulses are decreased to that side, so we get lower pressures. All right, so we are at 11 o'clock now. So I'm going to stop here. I'm going to post just a quick video. There's a little bit on some procedures, but that was the main bulk of this chapter, you know, and the signs and symptoms. So I'll post the quick video that you guys can review for the quiz next week. So the quiz next week is going to be on the last two lectures. If there's anything that I feel is kind of overly confusing, I'll admit it from the quiz, especially on these surgical procedures. I know there's a Lily quiz that she made, so I'm not going to try and trick you guys. But I think we covered a pretty good amount. Yeah. Does anyone have any questions about any of this stuff so far? About the symptoms and circulation? So anterior circulation, they're lateralizing symptoms. They're unilateral symptoms, affect one side. Posterior circulation, you know, those are non-lateralizing symptoms. They typically affect both sides. The posterior circulation would be more like your syncope, your collapse, your dizziness, vertigo, diplopia, double vision. Amaurosis fugax would be considered the disease is ipsilateral, so the same side. So if I have the left eye that's affected with amaurosis fugax, the disease is going to be on the left side, the left ICA. No questions for anyone? I know it's a lot. No? Okay. So you're free to go. So I'll post that video a little bit later today. So just for you to review. So it's just on some procedures for in terms of carotid arteries. And there really isn't too much. It's basically just like stents and endarterectomy.
Thank you.
You're welcome. Take care.
Thank you.
Thanks,
Bye.
Dan. Bye.
Thank you.
Thank you, Dan.
You guys seem so sad.
We tired.
Tired. I know. All right. Well, you guys are gonna pass. The seniors passed their vascular registry, so we're doing well.
Okay, well, that's good.
All right. Take care.
All right, thank you.
Bye.